a little longer. It's a little easy to get lost in the middle, I think, but try to stay with me. We're going to start with low thyroid, hypothyroidism. Very straightforward, pretty simple in my opinion once you kind of get the basics. Hyperthyroidism, though, is a little more complicated. It's a little more ambiguous as far as like what do we treat with, what's, there's more side effects of the medications and things to take into consideration, okay? So it's also can be more dangerous in the acute setting than hypothyroidism can. So disorders of the thyroid, just looking back at where it sits in the neck, I think this is important to remember when you're doing a physical exam, of course, but what other structures are also around it is important when you think of someone that's had a goiter, an enlargement, and what it can compress on. With the trachea, it can cause troubles swallowing, dysphagia. Also, I've seen people that have had damage to the recurrent laryngeal nerve following thyroid surgery because of its location next to the thyroid, and there's hoarseness. It's not unusual to have hoarseness like a week or so after thyroid surgery, but if it persists, that's a big problem, and that's unfortunate for people that have, are always hoarse. So it's also, think about the carotid artery, the jugular vein. There's some very important structures in the neck that don't need to be messed with if you're thinking about doing a fine needle aspiration, biopsy of the thyroid. Not a whole lot of room for error here. So we talked about the laryngeal nerve, the recurrent laryngeal, and we've already talked about the parathyroid glands and how they can be inadvertently removed during surgery. So remembering that they're embedded in the back. Palpating the thyroid is very difficult in my opinion, especially with a larger patient. It's hard to really get a good feel. I always do from the back. I know they have the anterior, way of feeling the thyroid. I've never done it that way. I've never seen people do it that way, really. Checking from the back is always a better method. The sternocleidomastoid muscle gets in the way, and it often tricks us. We think that the thyroid is enlarged or there's a nodule, and many times it's just the neck muscles that we're feeling, and we think it's the thyroid. So it takes a lot of practice. It takes doing it a lot to get good at it. And again, a thyroid nodule has to be pretty big before we can even feel it. 1 centimeter or greater in size before even an experienced practitioner can feel a nodule. So don't beat yourself up in the beginning, especially as you start to feel people's thyroids. It's tough to really distinguish a thyroid nodule. Sometimes the goiters are so big, it's just easy to tell, but the nodules are more difficult. Looking at the pathophysiology, just recall that it starts up in the hypothalamus with the TRH, the synthesis of thyroid hormone. Anterior pituitary is where the TSH is stored. And then that has a negative feedback relationship with the T4, the T3 that's produced by the thyroid gland. Typically with hypothyroidism, all you're going to really need to measure is the TSH. But at the beginning, it is important to have a T4 as well, and we'll go through why that is. But basically what now we can, but what it does is it rules out that it's a central hypothyroidism, okay? Because if the TSH is high, the T4 should be what? Low. If the TSH is high and the T4 is high, something else is going on, right? So you can sometimes get really weird lab results, and it makes you have to kind of think a little differently about secondary hypothyroidism or even tertiary hypothyroidism. That's rare. Usually you're going to have a high TSH and a low free T4, okay? So the most common cause of hypothyroidism is Hashimoto's, chronic autoimmune thyroiditis, okay? But there are other reasons that the thyroid can be low. If it's removed, that's pretty obvious. It won't be producing hormone. Radioactive iodine ablation as treatment for hyperthyroidism can result in hypothyroidism. You're kind of trading out an easier to treat condition for one that's tougher and more dangerous, which is hyperthyroidism. Also, I would kind of highlight drugs that can cause hypothyroidism. That's lithium and interferon. Okay, those are some ones to keep in mind. And amiodarone messes with the thyroid gland as well, and we'll talk about that more later. So symptoms. There's a lot of symptoms with hypothyroidism, and a lot of people feel like they have thyroid disorders, and some do. But because there's so many symptoms, it can be a little confusing. Sometimes I think as far as whether it's really the thyroid or if it's something else that's going on. But it's often checked when people come in with fatigue, weight gain. Those are kind of the big things you'll see it with. There's some more obscure symptoms that you might not think of as much, like diminished reflexes on physical exam. The cold intolerance, honestly, it has to be very severe for people to have much changes there in temperature regulation. This mixed edema, I have a picture of that here, but there is a fluid infiltration, kind of an edema, that does resolve after treatment, that you can see clearly in this picture. Hypothyroidism, being that it's autoimmune in nature, often comes in clumps that runs in packs with other autoimmune conditions. So that should be something you have in mind to rule out with people, is if they have hypothyroidism, they may also have Addison's disease or diabetes, type 1 diabetes. So those are just important to keep in mind, as well as vitiligo. So if you suspect hypothyroidism, a TSH is always the first test. I always add a free T4 to confirm diagnosis there and make sure it's not something strange. But once you've started treatment, you can just monitor with a TSH the vast majority of the time, unless something very strange is going on. Autoantibodies are often ordered by people. I would disagree with doing that on everybody that comes in. I think they're very expensive. So they're not indicated in every single case, and we'll talk about some of the reasons we should use them and when not to. And a lot of people too, I've found that when they have a high TSH, they also do a thyroid ultrasound, and that's not necessary. Unless you suspect like a nodule or a goiter that's compressing, if you're having trouble swallowing with a very large goiter, there's really not a need to do an ultrasound in a hypothyroid patient, okay? So treatment, pretty straightforward, levothyroxine, Synthroid, it's the mainstay of treatment. You'll find that certain clinics, endocrinologists especially, will do some combination therapy, and that gets more complicated. And a lot of the research I've read does not show much benefit for patients with combination therapy. But I've had some patients that will not, that's all they want. Okay, they want to use Armour Thyroid, which is a combination of T4 and T3, or they want Cytomel added on to their levothyroxine. But it's definitely not indicated for monotherapy, T3 treatment alone, which is Cytomel. And the combinations, you'll find that the pharmacies often don't have, you can't keep Armour in all the time. I ran into that issue. Plus, it's not very predictable from comparing apples to apples. Like some will say 60 grains, but if you compare it to another 60 grain, the actual composition of the T4 and T3 is different. So it's kind of a nightmare for a clinician for someone to prescribe Armour, in my opinion, because it's really hard to regulate levels. But some patients really, really like it. They feel better on it. So Synthroid, levothyroxine, some things I would keep in mind with every patient you start on, they need to be educated on how to take it appropriately, or they're going to have struggles getting normal levels of TSH. It needs to be taken on an empty stomach. I tell patients at least 30 minutes before their first meal or drink or anything. I have a lot of people that wake up in the middle of the night to pee or something. I just tell them take it then, because then you don't have to worry about it. You can get up and you can eat, okay? But if it's taken with food, the absorption is going to be irregular. It's going to be higher with certain types of foods, lower with other foods, and it's going to make their levels go up and down. Another thing that I think is very important to know with Synthroid is that calcium and iron can block the absorption of Synthroid. Okay, calcium tablets need to be separated by about 6 hours, and iron tablets by about 12. That's very hard to do when someone's being treated for anemia and they're taking iron 3 times a day. Okay, but I've had patients that are on like 300 plus micrograms of Synthroid because they're also taking iron, and the iron is just negating the effect of the Synthroid. Once that iron is removed, though, then they would have way high levels of Synthroid in the blood. So, sometimes people will be referred to an endocrinology office just because they're on high levels of levothyroxine, and it's a simple fix. They're just taking calcium and iron alongside of it. So that's something you can do on your own and not have to send people off. So let's do a practice case. I think this is important to see some differences in presentation of patients and how you would replace their levothyroxine. So we have a 150-pound, 33-year-old female with fatigue and myalgias, muscle cramps. I should have said that. That's a fairly common presentation as well with hypothyroidism. 10-pound weight gain over 3 months. TSH is drawn. The level is 12. so it's high. What would you start this lady on? What dose? Any thoughts or ideas? You want to take a stab at it? Or maybe you've already gone through looked at the next slide. Any thoughts? And when would you bring her back?
25 milligrams in 2 weeks.
You would start 25?
Or micrograms.
Micrograms?
Yeah.
It's not a bad idea, especially for our next patient that's a little older, that has some heart issues. You would start slower, but someone that's 33 years old without any other issues, it's in good health, you can start a little higher than that. For someone of this size and her age, somewhere around 88 would be a good place to start. You know, even 50, you can make a case for other ones, but you're going to have to, at 25, you'd probably have to see her back quite a bit to get any kind of symptomatic improvement. But with our next case, you'll see that that's actually where you need to start. If she returns in about a month with a TSH of 6.5, she's feeling better, she's lost some weight, her energy's better, but it's not baseline, no longer having muscle cramping, would you leave it, change it? Yes? Leave it? Yeah, I think at this point that's a pretty good response. And if you go ahead and increase it, you have a really high chance of over-treating her and basically making her hyperthyroid. So you kind of create another problem on the other side. Yes?
So is there a like treatment goal for if
the TSH level?
TSH is like
I shoot for 1.
Okay.
That's where, even within the range of normal, it usually is like 0.4 to like 3.5 or 4 on the TSH. I try to get as close to 1 as possible. I find that people that are, even if they're normal on their lab, the assays are different. Maybe that 4 is even normal for that assay. They feel tired and, you know, so I try to get as close to 1 as possible. But if you go less than that, like if you're like at 0.05, then you're going to have bone turnover issues and other things that happen with hyperthyroidism. Okay, any other questions here? Okay, so I would leave it for this particular person. I mean, some of this is just judgment. And then I'd repeat it in about another month, okay, and see how she's doing there. If it remained high, then I would then increase. I've also found that even a small amount of levothyroxine, like an extra half tablet a week, can make a difference. So oftentimes people are between doses. Like the 75 is not enough, but the 88 is too. So you kind of have to mess with it a little bit and cut, maybe half of a tablet one day or something like that. So another case here, this is a 75-year-old with fatigue, multiple comorbidities including type 2 diabetes, high blood pressure, high cholesterol, atrial fibrillation, and osteoporosis. His TSH is a lot higher than hers was. It's 22, so it's more severe. He weighs 175 pounds, so he weighs more. He has a higher TSH, but if you were to start him on the same dose, you'd cause a lot of problems. Okay, you could, and that's why it was a good point that you made to start low and go slow. So someone in this age range needs to be started on a much lower dose of levothyroxine. I typically titrate it. I'll give them like a 25 microgram tablet, even have a half tablet of that for a week, then a full tablet, then a tablet and a half for a week, and then do some kind of schedule like that. But you go slow with people that have atrial fibrillation is the thing that should stand out the most, okay, and his age. Does that make sense on the 2 different patient types and how to treat them differently?
So at what point, like say they're on levothyroxine, and what if they're like having a conversion issue, because that's T4, if they're having problems converting it to T3, would you try like Armour or Natrothyroid?
That would be the next step,
Okay.
yeah.
So just if like they didn't improve with like fatigue and symptoms?
Yeah, and I would give it some time before I went to that. But yeah, I mean, if some people just do not feel well on T4 alone, then it's, it's kind of clinical judgment whether you want to try the T3 combo therapy, but I sometimes add Cytomel in a small dose to see if that helps.
Okay.
I prefer that over Armour, but
Okay.
people are all different about what they, what they want. Anything else? Okay. So subclinical hypothyroidism happens a fair amount, so you need to be aware of that. It's when the TSH is elevated, but you have a normal T4 and a normal T3. So what this usually represents is early onset Hashimoto's that you've just caught before it's been full blown. Does that make sense? But it can't just stay there. I've seen some people that just stay in this subclinical picture, and there's always this debate about should we treat, that or let it be. And so here's some good guidelines to go by. If the TSH exceeds 10, even if the T4 is normal, I think that's worth treating, okay? If it's between 5 and 10 and you have positive antibodies, which is that test I said that's fairly expensive, this is a time you could use it, okay? The anti-TPO antibodies, then you would treat it. But no matter what you do here, you always start low. Like you mentioned here, 25 to 50 micrograms will probably do the trick, and repeat levels in 6 to 8 weeks, okay? So the disadvantages is just the side effects, cost of treatment, cost of labs, but there are some benefits that are possible. There's been research to show that it can reduce cardiovascular risk factors, and improvement of mood, and even lipid profile with levothyroxine and subclinical. So when do you send people out, kind of the more tougher patients that are not your standard hypothyroid patients? Anyone that's pregnant probably needs to see an endocrinologist. There is a very high risk of even neonatal death, other cognitive issues that can occur with women who are with low thyroid. You need a lot more thyroid hormone during pregnancy. It's around 25% extra needs, which we usually just increase from the onset because they're going to need it. If there's large goiter or nodules, that might be a good referral. If they're in a cluster of other endocrinology, endocrine abnormalities, kids need to be treated a little differently. So these are reasons to refer out. So briefly, we'll talk about hypothyroidism in pregnancy. I mentioned some of the adverse effects that can happen to the child. It requires more frequent lab testing and higher levels of thyroid hormone. Okay. So a couple of practice questions before we wrap up hypothyroidism. Just basic. An elevated TSH is what?
Hypo.
Hypo. I've had a lot of people refer for, they think high TSH, oh, it's hyperthyroidism. So make sure you have that straight. And the most common cause? Hashimoto's, right. You guys are listening. Okay, any questions on hypo? Yeah?
So after establishing the patient who's hypothyroid and putting them on replacement therapy for T4, like levothyroxine, would you expect all of their symptoms to also diminish? Because I kind of heard you say armor have some than others.
It's a good question. There are some patients that I feel like don't respond, they don't feel great even at a normal TSH, and that it presents a conundrum to a clinician because you can increase it in good faith because you're actually causing high risk of other things, atrial fibrillation, osteoporosis. So I will not budge from increasing even when people feel tired or they're having symptoms because of that. But you're right, there are a fair amount of people that even though their levels are normal, they don't feel as good as they would hope. So I don't know if that's other factors that are playing in or if it's the conversion thing. So that's just kind of a case-to-case discussion of whether maybe you're missing something else that's entirely separate or trying combination therapy might be worth a trial. Does that make sense?
Yes.
Okay. Anything else? Okay, the home stretch, guys. Hyperthyroidism. Okay, so thyrotoxicosis or hyperthyroidism, about 1.2% of the population in the U.S. Has hyperthyroidism, and the most common cause is Graves' disease. It's also called a toxic diffuse goiter. So the entire thyroid is large and overproducing, okay? There are other causes, and we're going to go through all of these, and that's when I think I can start to lose people, okay? Because there's all these other causes. You can have lots of nodules that are overproducing, kind of like the parathyroid has an adenoma. You can have an adenoma essentially of the thyroid gland. You can have one thyroid nodule that's overproducing. There's some kind of strange, more transient issues like subacute from an infection that can also affect the thyroid. After pregnancy, you can have postpartum thyroiditis. So there's a lot of different causes, and we'll go through these one by one. One I want to mention, sometimes people don't list all their medications, and I've found, like I almost did this huge work about someone, they were on too much levothyroxine, you know, and they just failed to mention that they were taking it. So making sure that you have all the information, because that's a much easier fix, right? Just lower the dose of levothyroxine. So symptoms. It's a misnomer to say that people that have hyperthyroidism are hyper. They're not. They're very tired usually, worn out. Heart racing, those are some of the biggest. So heart racing and muscle weakness and fatigue, I'd say, are kind of the most common symptoms I see clinically, and the excessive sweating, kind of heat intolerance. It's like a woman going through menopause. My husband has this, and it was pretty funny, but I mean, he's always was hot. I'm like, what is wrong with you? I should have known, right? So you'll see this increased appetite, but not gaining weight, diarrhea. I mean, there's just a lot of things that can go wrong in women. You know, you'll have menstrual irregularities that can sometimes prompt you to do a TSH, but sometimes it's just a huge goiter that people come in with, like, what's this thing on my neck, you know? So there's a lot of different ways people present. Sometimes I've even seen people present with more concerns about their eyes, which we'll talk about from Graves' disease, and not the other symptoms so much. So you can see a lot of different presentations. So here's a picture of Thyroid Eye Disease. It's also called TED. As you may have already be aware, Graves' disease also affects the eyes, and in a lot of patients. Not everybody gets this that has Graves' disease, but it can be quite a life changer. I had a patient recently, actually at Good Shepherd, that was almost in tears because people were saying he was a drug addict, and he couldn't get hired. He was having trouble with his employer because they said he looked like he was on drugs. And it's his thyroid, like he has thyroid eye disease, you know, but it can mimic kind of this bugged out. He said, everyone says I'm bugged out, you know, like I'm you know, like just real tense, and so it can be very disfiguring. My husband had to have surgery twice to fix his eyes. The eyelids have to be adjusted because you can have dryness, especially overnight, because they don't fully close down over the eye as the eye is pushed forward. So it's quite an ordeal, and there's also struggles with seeing side to side and up and down. Anyone that was taller than my husband, he had to like move his whole head to look up because his eyes did not go up. So the eye muscles become very rigid and they just don't move right. So it can really cause a variety of problems, not only just from a cosmetic standpoint, but just from driving well, your peripheral vision, all kinds of things that you just cannot function as well with thyroid eye disease. An ophthalmology referral is very important for someone here. DMD is great here, and they do a lot of surgeries on people and kind of lead out in research, actually in the nation, with thyroid eye disease. So kind of cool that it's local. Yes?
Does it always have to be treated surgically, or can it like go away once the Graves' disease is under?
It doesn't. It doesn't go away. In fact, radioactive iodine sometimes makes it worse. And methimazole and PTU don't correct it. So it'll often just keep getting worse unless it's fixed, because it doesn't affect the antibodies. They're still circulating in the system, and that's not removing any of that. So yeah, most people, once they start to have this effect, it's kind of their choice. I mean, they could choose not to have surgery, but it will start to be a bother. Yeah, for sure. Oh yeah, if it's asymmetric, you need to do an orbital MRI to make sure there's not a tumor that's causing one eyeball to bulge more than the other, okay? So, approaching a patient with hyperthyroidism, sometimes the only thing you'll notice is that they have a high heart rate. I think that's one of the, people can come in for just a yearly exam and their resting pulse is like 115. They probably have Graves' disease. It could be some other cardiac issue, but this is something that should be high on your differential. Changes in body weight based off history, of course eye signs, faster respiratory rate. Those are all what you'll see on a physical exam. Pretibial myxedema can happen. It's more rare. A deposition of hyaluronic acid, usually in the kind of shin area. More common in patients that also have the thyroid eye disease. Treatment is steroids. So this is a more rare condition, but it can happen. So from a laboratory standpoint, you measure TSH when you suspect hyperthyroidism. And how this differs from hypo is that you would also do, I would always do a free T4 and a free T3. Okay, so you'd add that free T3 And to me, even with management of, even when you're treating somebody, I kind of order this whole panel again. So it's a little bit more, you know, with a hypothyroid patient, you get by with just a TSH. I don't see that that's the case with hyperthyroidism, because often the TSH lags behind, and you get a more accurate picture with the free T4 and free T3 combined. I prefer a free T3 and T4 over the total levels, because the total T4 and total T3 can be affected by binding protein abnormalities, so it's not as clear of a picture. The ratio of the T3 to T4 can be helpful too, because you can see that in Graves' disease, you typically have much higher T3 levels than T4, so that's kind of helpful. Autoantibodies, there are different ones that you measure for Graves' disease and Hashimoto's. They're also expensive and not always necessary, but there are times that you do need to check these as well. TSI is the one that I would use the most for Graves' disease. So an uptake and scan is kind of the next step after you confirm biochemically that someone is hyperthyroid. You need to know why. So an uptake and scan helps you differentiate the cause of the hyperthyroidism. Before doing these, you need to make sure that they're not on any medications that interfere with the results, such as amiodarone, or even antithyroid medications. Like if you're pre-treating someone before this test is ordered, you need to make sure that they hold their methimazole or PTU before having the test, or it'll mess it up. And you can't do it during pregnancy. So that's when you could do the antibodies, okay? So when you get the scan back, you can kind of tell what the cause is. If you have an elevated diffuse high uptake, then you're looking at Graves' disease, okay? Normal uptake is usually less than about 30%. Graves' disease is usually, most I get back are between 80 and 100% uptake, okay? A toxic multinodular goiter, you'll have kind of patches of high uptake, which makes sense because the nodules are overproducing, but the rest of the thyroid is in a normal range. Or a hot nodule, like the toxic adenoma, is just one area that's overproducing. And then there's some causes of low uptake hyperthyroidism that we'll go through at the end. You know, painless thyroiditis, postpartum thyroiditis, there's a list here of things that can cause low uptake. So there's a picture of an uptake and scan. You can kind of compare normal to Graves', which makes sense. The entire thyroid has diffuse elevated uptake. Toxic multinodular goiter is kind of the patchy one, and then toxic adenoma with just one nodule. It looks like in the isthmus that's overproducing. So first things first, no patient with hyperthyroidism should go home without a beta blocker if their heart rate is elevated. So that's very, very important to remember. Most literature will say anything exceeding 90 beats per minute, they need to be on a beta blocker. Here's some different examples of beta blockers you could use. Some of them actually block T4 to T3 conversion, so that's kind of important to keep in mind. And some are just used IV for like Thyroid Storm. So kind of focusing in on Graves' disease and the treatment is what we're doing here. So homogeneous increased uptake. Treatment options. In the U.S., radioactive iodine ablation is by far the most common treatment option for Graves' disease. Okay, most people here end up with radioactive iodine. In Europe and Japan, that's not the case. They hardly ever use radioactive iodine. They primarily use antithyroid drugs or surgery. So this is kind of important to keep in mind. And why that is, there's a lot of fear, I think, about using radioactive stuff. I mean, who wants to swallow radioactive material? Actually, I had a patient once when I was in New Mexico that got stuck at the border with the Geiger counter because she had been ablated. I'm like, man, it was like a week or two before and still set off, you know, the border issue. So it's kind of weird, right? To take a pill that's radioactive. And a lot of patients, for a good reason, have questions. Why am I ingesting something that, you know, is radioactive, and is this going to cause cancer, and is this going to cause problems? And they've done tons and tons of studies, and really in the U.S. they still feel like the evidence, the benefit outweighs the risk. You know, that the cancer, the rates, they can't really prove a connection. But Europe and, you know, primarily Europeans would disagree and say, no, it's just too crazy. They treat it with the antithyroid drugs. But what you'll find is the antithyroid drugs have a whole other list of concerns and side effects and issues. So it's not like you have one clear-cut choice, like this is truly better than this. So that's why there's a lot of, debate. And then some people just do a thyroidectomy, they just want the thing out of there. But as we learned from the previous lecture, the risk of low calcium, you have a scar. I mean, it's not like this is an easy way, and it's surgery, so you're taking a risk to have it removed. So there's a picture of radioactive iodine. It's an outpatient procedure. It's actually fairly quick. You go in, you take a pill, and then you leave. So there are things you have to be careful with, and I've listed out all the precautions, but you have to really counsel patients before they do this. First off, you don't ever give it to a pregnant person, and you need to confirm that before that's done. Don't take someone's word on it. The other thing is that they shouldn't be around like small children, close quarters with people. I actually tell people to sleep in a different bed, for like up to 5 days. Use a different bathroom. The supervising physician I had originally was very cautious about this, and I see that the reactions to this vary depending on the endocrinologist. I've had some endocrinologists that really have lengthy precautions, even people recommend that they go stay in a different location by themselves, take off work, you shouldn't be around anybody that you could expose, like a pregnant person. And then other people are like, nah, it's all eliminated within like a couple of days, not a big deal. So you'll see a lot of different, perspectives on that. But here's some good guidelines to follow. Close contact of any sort, of any kind is not recommended for 5 days. No breastfeeding, of course, and this would need to be discussed beforehand. Double flushing the toilet, there you go. Throwing away the toothbrush when you're finished. The other thing is kind of a pearl on that is I often would tell people to suck on lemon drops the day before the procedure, because the salivary glands can also be stunned because they're of a similar composition, the thyroid. The radioactive material is also taken up there, and so people can have a very dry mouth and issues with their salivary glands. The lemon drops seem to help. So when do you consider radioactive iodine? Treating Graves' disease in pregnancy is really hard. And so if you have a young female who's planning on having a family someday, but it's kind of out in the future, it's often best just to take care of the problem before you even get to that time. Because the antithyroid drugs can't be used, well they can be, but you have to alternate trimesters that you use them, and then there's high risks of, effects to the child. So that's someone that you could probably say that would make sense to definitely use radioactive iodine before, and you want them to wait up to 4 months, males, females up to 6 months before they would try to have children. If you have a high surgical risk patient, like an older person or has other comorbidities that just can't deal with the anesthesia, this is a good option. Or if they've already had a lot of neck surgery for other things, they have a lot of scar tissue, so they're not a good surgical candidate. You don't have access in a rural area to a good surgeon. These are some reasons, and like I said, in the U.S., most people just go right to radioactive iodine. So, yes?
Is this a one-time treatment? Or
Yes, usually. It's not always effective. There are failure rates, but typically it just takes one time, if the dose is calculated correctly. And it's based off the uptake, is how they dose the radioactive material, yeah. So drawbacks, you basically create another problem. When you ablate somebody, they're hypothyroid, unless they give the exact perfect dose, which I've not seen very often. Usually people just go low, okay? So you have to give them levothyroxine the rest of their life. Some people are very upset if you don't educate them on this for good reason. They think they're fixing their problem, and they're like, why do I have to be on another medication? They need to know that before they go in, okay? Thyroid Storm, if someone is very thyrotoxic, meaning their T4 and T3 levels are very high, and you ablate them, it can kind of just like release all of that that's stored up in the thyroid at once. It makes the thyroid gland kind of leaky, for lack of a better word, and it can kind of precipitate this like very, very high levels of T4 and T3. This happened to my husband. He almost went through Thyroid Storm and was very, very sick for almost a week after radioactive iodine. So the idea is to pre-treat patients prior, and there's a little bit of controversy on that, but you can lower them down with antithyroid drugs before giving radioactive iodine ablation so they don't have the same chance to have these issues. It can worsen ophthalmopathy, at least temporarily. From the eye doctors I've spoken with, this is going to happen anyway, but it kind of makes it happen quicker. So instead of prolonging what would happen with thyroid eye disease over a period of a year or two, you can have that happen over a period of a month or two after radioactive iodine. So people have tremendous differences to their eyes right away. So that's kind of a drawback. Contraindications, we talked about this. If you suspect any kind of thyroid cancer, there's a familial, thyroid cancer history, do not give people radioactive iodine. If someone's in a nursing home and they can't get away from people for a week, that's, probably don't want to give them radioactive iodine. There's some different circumstances that you could think through, just lifestyle, that you just can't comply with the precautions. Child care, stuff like that. So when do you consider anti-thyroid drugs? A lot of elderly or other medical comorbidities, people that aren't good surgical risk, you can give these and they work just fine, especially at lower doses and have lower chances of side effects. We talked about it, they can't follow the safety precautions, limited or no access to a surgeon. This kind of starts to get repetitive, but you start to go through and see when to use which, okay? So other drawbacks of anti-thyroid drugs, the side effect profile is quite lengthy, especially for PTU. It has some, very serious side effects that can occur. With methimazole, the main thing I would counsel everyone that took methimazole is on agranulocytosis. The risk of that is it's low, but if people had a sore throat, a fever, or mouth sores develop while on methimazole, I would tell them to stop it immediately and to come in for a CBC to make sure that they don't have this. So that's just some counseling that has to be done on the front part. Liver hepatotoxicity is fairly common, not like super common, but it can happen. There's a lot of side effects with these drugs. So that's the agranulocytosis I talked about. We talked about that. So how do you choose one over the other? There's basically two drugs that are in the anti-thyroid drug category. Methimazole, some people call it methimazole, or PTU. So every patient, I would say start with methimazole or methimazole unless there's a contraindication to it. That's kind of your starting place. PTU is a little more side effect heavy, and so that's where I always start is with methimazole. Compared to methimazole, PTU has a higher risk of anti-neutrophil cytoplasmic antibody positive smell vessel vasculitis. That's a lot of a mouthful there. Agranulocytosis is actually higher with PTU than methimazole, and this FDA actually issued a safety alert with PTU on liver stuff. So, but the problem is if someone's pregnant, methimazole is associated with choanal and esophageal atresia when taken the first trimester of pregnancy. So often someone will be put on PTU for the first trimester, and then the second and third they'll be switched over. So these are just some reasons when to use which. Thyroidectomy, recall this is all for treatment of Graves' disease, okay? These are your options. For thyroidectomy, if someone has a large goiter, it kind of makes sense if it's causing them problems. You kind of treat two things at once. You remove, the compressive goiter, plus you treat the Graves' disease. If there's any suspicion of thyroid cancer, it's the same kind of difference. You probably have to do the surgery anyways. So that makes sense. And sometimes people present with not only hyperthyroidism, but hyperparathyroidism, and they have to have their parathyroid glands removed, so you could kind of get both done at the same time. So those are some ideas on when to use that. Disadvantages, we talked about the hoarseness, the low calcium, anesthesia risks, and the cosmetic, the scar on the neck. There's a picture of a goiter. Okay, so let's do a case study for Graves' disease. And by the way, this is kind of a pretty typical presentation. Someone with Graves' disease, female, she's probably in her 30s. This is kind of where it most common would happen in a goiter, okay? So, 20-year-old female presents with a resting heart rate of 110, fatigue, a large goiter without nodularity, irritability, shortness of breath, no signs of exophthalmos. What labs do you start with?
You say pre-T3, pre-T4?
Yeah, all three is what I would start with. You may also, if you're really suspicious, I'd probably also add a CBC and a CMP, because if I think I'm going to have to use methimazole, you want to make sure that their liver function is good before you start. and that they're not already low on white blood cell count before you start someone on methimazole. While you're waiting for the results, any thoughts on supportive therapy?
Beta blocker?
Beta blocker, yep. And I would do an EKG of this person in the office, make sure you're not missing something else. So you guys did good, and you would go ahead and put an order in for a thyroid uptake and scan. That can take a little while to get back, so you kind of have to treat in the interim. Other labs to consider, we talked about the antibodies, but I think you guys, if she was pregnant, you wouldn't want to do an uptake and scan, right? Because of her age, you would need to actually confirm that before doing an uptake and scan. Okay, so strong suspicion of Graves' disease, placed on a beta blocker, you guys got that. Reasonable example, I just put a 10-alone 25 BIDs, that is a possibility. And I also tell people, I've had some people that start on beta blockers and they don't like the way they make them feel, and they'll just stop them. I mean, they'll be taking them for a week and they're like, I don't like this anymore. And I always tell them, you can't just, it's not a good idea just to stop it. You need to kind of slowly get off, let me know. Yeah, so I usually educate patients on the importance of not just stopping it abruptly. So you'll get the TSH and free T4 back pretty quickly. The free T3 is usually a send-out lab. I would go ahead and start that discussion with them about treatment options so they can start to be thinking about this. This is a lot to take in. Whatever method you choose, there's kind of a lot to weigh, talk about. So I already go ahead and start this discussion. What would you want to kind of discuss with this particular person?
Pregnancy, right?
Yeah? If she wants to have family, or she, you know, yeah, what her thoughts are. Any other thoughts?
Kids in the home.
Yeah? Could she have time off work or whatever she needs to do? Childcare, yeah.
History of thyroid cancer?
Yes, yeah. Good job, guys. You guys did good. I think you answered all those. Okay, so another just discussion of this one. If you choose radioactive iodine ablation, and she feels like that's the best choice for her, you have to have the discussion of whether to pre-treat. And like I think I mentioned before, if someone's above 2 to 3 times the upper limit of normal on their T4 and T3, it's a good idea to pre-treat them with methimazole. Okay, you don't want to do radioactive iodine when they're really high. It can make them feel really bad. Let's see here. The only downside to that is there's some literature that shows that pre-treatment with methimazole can lower your chance of radioactive iodine being effective. So that's kind of the downside. But I feel like you could do another one if you had to, rather than make someone, you know, real sick. You have to discontinue methimazole 5 days before the ablation, or the ablation will not work. So that's important. And often, after the ablation, they need to restart the methimazole for a period. It's not like an immediate, you know, fixed. It takes some time. So usually restart it and kind of taper it off as the labs start to normalize. Yes?
If you were to have to do the second dose of the iodine, do you have to tailor the doses differently than the
I'd
first?
probably give them less radioactive iodine, yes. Radiologists typically dose all that. I don't have a whole lot of, honestly, knowledge on what doses they, you know, how they dose it, but the radiologist would always, you know, kind of plan that out. Don't forget the pregnancy test, and counsel the patient to delay conception for 4 to 6 months because radioactive material can still be present. Warn of risk of agranulocytosis, post-ablation guidelines. There's kind of a lot to go through here with each patient. And then initiating levothyroxine, you know, I'd include a free T4 when you're measuring because of the, it can lag behind. The TSH can take some time. If you choose, if this person was like, no, the radioactive iodine sounds crazy, there's no way I'm going to do that, and they want to do the anti-thyroid drugs instead, we talked about all the risks that you would go over with her. What I usually tell people is that the higher the dose, there is a dose-related side effect. Does that make sense? The higher the dose, the higher the chance of side effects. So I just kind of make the point that we are going to try to taper this as quickly as we can. It often starts with 30 to 40 milligrams of methimazole, but it can get down to as low as like 5 or 10 and maintain a euthyroid state. At that point, you do have a lower risk of side effects. Some people choose to do anti-thyroid drugs for about 1.5 years, and then you try to get them off of it. Okay, and that can work. In fact, that's what they mainly do in Europe. The rates of remission kind of vary depending on the patient, but that can actually be a pretty good choice, is to try that for a year and a half and then try to get off of it, see if it works, and if it doesn't, then maybe consider radioactive iodine or something like that. But some people prefer that. So, determining remission. So the rates of remission in the U.S. after discontinuing antithyroid drugs, not very good, right? You don't have a great chance of it working. Now, there's a higher chance of it not working if you have a larger goiter or higher antibodies. So you can kind of, based off the patient, if they have low antibody profile, they don't have a huge goiter, they have a better chance of this working, okay? In Europe and Japan, they have different rates, but they use methimazole for longer periods of time, 5 to 6 years before they try to stop it, okay? If people smoke, that not only affects their eyes terribly. Thyroid eye disease, one of the worst things you can do is smoke. It makes it so much worse. It also affects their likelihood of recurrence. So, thyroidectomy, if she chose a thyroidectomy, remember to kind of counsel on the side effects, low calcium, hoarseness, hypoparathyroidism, all those types of things. Within surgery, there's a holistic guidelines of how to manage someone that's hyperthyroid. You don't want to do surgery on anyone that's very thyrotoxic. You have very high risks of heart issues with that. Potassium iodine is given. It lowers the bleeding risk. And the calcium and parathyroid hormone levels are constantly monitored and then supplemented as needed. There's some pictures of scars over time, kind of what to expect. You can tell this lady in the red jacket there. I mean, over time it looks pretty good, but you can still definitely tell. I don't know why I put that there. So I like llamas. You know? See, everybody's good, everyone's awake. Okay, so Thyroid Storm. Okay, so if someone's very thyrotoxic and they're on like high doses of methimazole and then they decide it's not working for me or I don't like the way it's making me feel and they just stop it, kind of like the beta blocker, they have a really high risk of going into thyroid storm at this point. Someone that is undergoing surgery when they're severely hyperthyroid, they're high risk for a thyroid storm. Maybe they're ill for other reasons, they've got other chronic diseases. These are people you need to be very cautious about with thyroid storm. And what thyroid storm is basically a multi-system failure decline. Everything kind of goes south. That's a bad way to describe it maybe, but you basically, the supportive therapy here is huge. The heart rate is an issue, there can be congestive heart failure, the blood pressure drops low, people have a very high temperature, you have to use cooling blankets a lot to kind of manage their temperature. Psychosis, it's a very dangerous thing when someone's in thyroid storm. Beta blocker therapy is used IV, so that's also antithyroid drugs. There's a mixture, PTU is done first, and then methimazole is given, inorganic iodide is given, steroids are often given, cooling with acetaminophen and cooling blankets, IV. There's a lot of stuff that goes on with treating someone in thyroid storm. It can be quite dangerous. So that's why hyperthyroidism is a little more scary than hypothyroidism to me. It can kind of result in more acute issues. Okay, so Graves' disease, we have finished that unless someone has a question. Yes?
If someone has hyperthyroid storm was to show up in like the ED, what test would show that they're in that state?
Well, I mean, their T4 and T3 would be tremendously high,
okay.
But you'd also have more like clinical symptoms that would make you think of that. Maybe I also see some renal issues, renal failure, hepatic failure. Plus, they would be running a temperature. Their heart rate would be sky high, respiratory rate. They're just kind of having, you can see physical symptoms that give you that indication as well. Does that make sense? Mm-hmm. Okay. Okay, so moving on to toxic multinodular goiter and a toxic adenoma. How you diagnose and treat those. Some similarities, but also things to keep in mind that are different. Same three treatment options, okay? So we have, for high thyroid, we have basically radioactive iodine, thyroidectomy, or methimazole. But you'll find here that the low-dose methimazole is used less for these types of issues. When you compare the treatment options for toxic multinodular goiter, The risk of treatment failure with thyroidectomy is less than 1%, pretty good odds. But with radioactive iodine, you have a higher risk of treatment failure. A lot of people will require antithyroid drugs after 3 and 6 months, okay? So not as effective with radioactive iodine. The risk of hypothyroidism, though, with a thyroidectomy, of course, is 100%. With radioactive iodine, the risk of hypothyroidism is a little less, okay? Because it often just kind of concentrates in the areas that are hyperfunctioning, and so the parts that are working, normally tend to make up the slack, okay? When you're looking at toxic adenoma and risk of treatment failure, thyroidectomy is less than 1%. This is especially useful, like if someone has on one side of their thyroid just an overactive nodule, just removing that lobe often works really well because then the other lobe can maintain normal thyroid function, okay? Let's see here, risk of hypothyroidism. You guys can read through some of the details. I don't want to bore you with reading it for you. Just a reminder of what we're looking at, the C and D is the toxic multinodular goiter and a toxic adenoma. So factors that favor a particular treatment, someone that's high up in age is not a good surgical candidate. Even though the radioactive iodine is not as effective, you might still give it a try because that's kind of what you got. So thyroidectomy, oftentimes with these large nodules, they're having compressive symptoms, so that's kind of a no-brainer as long as they're a good surgical candidate, okay? Post-op and post-radioactive iodine recommendations is very similar to Graves' disease, but there's a few exceptions. They don't use preoperative iodine, and typically a greater risk of post-operative hypocalcemia exists in Graves' disease, so that's one difference compared with toxic multinodular goiter or toxic adenoma. But you still kind of follow the same protocol of measuring serum calcium and intact PTH. After surgery, you want to start people on a dose based off their weight at 0.8 micrograms per pound. So that's kind of the starting point. And again, less with the elderly or those with heart conditions. What about antithyroid drugs? They don't induce remission, so that's the downside. I mean, this is going to be a lifelong choice. If someone wants to take antithyroid drugs instead of doing one of the other two options, you shouldn't say, well, you can get off of it after a year and a half. This is kind of like, you're going to have to keep doing this. But if you can use a low dose, it's not a bad option. Maybe 5 milligrams or 10 milligrams of methimazole might, provide a good option for somebody. Okay, so that's toxic multinodular goiter and toxic adenoma. We're going to go into Graves' disease in the pediatric population. I probably should have put that before that other section, so my apologies. But let's briefly look at the pediatric population with Graves' disease. Same three treatment options, but don't use radioactive iodine in children under 5. Okay, their bones are still, the development of the bones is important, and that's kind of the endocrine recommendations is no one under 5 gets radioactive iodine. Between 5 and 10, they use a smaller dose. If it's less than 10 MCIs, then it's reasonable, but if it exceeds that, if they think it's going to be more to treat it, then it's not a good option. Still need beta blockers. So this is really a referral. I just want to give you some pearls on what to think of with kids, but this is kind of a subspecialty with someone, a pediatric patient with Graves' disease. Okay, so we talked about subclinical hypothyroidism. There's also subclinical hyperthyroidism. So you have a suppressed TSH and a normal T4, T3, okay, and what to do with that. It's 1% of the general population. It's usually in the elderly. Toxic multinodular goiter is the most common cause. But there are other things, and I think this is really important to keep in mind. A lot of people that are hospitalized will have a slightly suppressed TSH, and it has nothing to do with their thyroid, really. Because it's just them dealing with illnesses and other things going on that can cause this, and it's transient. It'll go away. So, if there's if you're hospitalized for a long period of time with a chronic illness, it's not unusual for the thyroid to kind of take a hit a little bit and then recover. Okay, it's not like a long-standing chronic disease. You'll want to make sure that subclinical hyperthyroidism is a persistent problem because of the way it can be affected transiently with other illnesses by repeating the labs in 3 to 6 months. If it remains in the same way, then you might need to treat it. So why worry about subclinical hyperthyroidism? Because of the effect on the cardiovascular system, there's a higher risk of atrial fibrillation in patients with subclinical hyperthyroidism. And the second thing is osteoporosis. Okay, So a suppressed TSH really increases bone turnover and causes osteoporosis. So that's why it needs to be treated. To treat or not to treat, if the TSH is persistently less than 0.1, you'll want to treat. Anyone over 65, any thoughts about why that would be? Higher risk of AFib, higher risk of osteoporosis. Yeah. The same with postmenopausal women, they're high risk of osteoporosis. Okay. So what's causing the subclinical hyperthyroidism? You probably still need a uptake and scan. If it persists in this laboratory picture for up to 6 months, you'll need to do an uptake and scan and kind of see what's causing it. It may just be a very mild form of Graves' disease, like a 40% uptake, something like that. Or you could start to see that toxic multinodular goiter, it just hasn't fully developed yet. So sometimes you're just catching them early on in the disease state. And so the treatment would be the same as what we already went through, depending on which one of those things it is. Does that make sense? Okay. So hyperthyroidism in pregnancy, again, probably a referral, but let's go through some of the pearls here. Remember, things to remember, there is an adjusted reference range on labs during pregnancy for T4 and T3 because of the estrogen levels, and that's really important to keep in mind. And there's trimester-specific normal ranges, so that's very important to think about. Early pregnancy, the physiological changes can mimic a biochemical hyperthyroidism that does not require therapy. There is something called HCG-mediated transient TSH suppression, which really isn't an issue with the thyroid, it's more HCG-mediated, okay? So as the levels of that hormone go down, so does the thyroid kind of resolve, the issues resolve. But women that are pregnant, because you're looking at the age range, of the most common time for Graves' disease to happen is often too when women get pregnant. And so hyperthyroidism in pregnancy is not uncommon, or Graves' disease in pregnancy is not uncommon. And that's a problem. It's hard to treat. Think about too a molar pregnancy. There's some other things that can complicate this picture that you need to rule out. So management of transient HCG-mediated TSH suppression should not be treated. Okay, there's no need to put the risk of the side effects with the anti-thyroid drugs in pregnant women with this. You just repeat the thyroid function test, keep an eye on them every month or so. Okay. If someone has Graves' disease that's diagnosed in pregnancy, remember methimazole is not indicated for the first trimester, and PTU is not indicated after that. Use the lowest possible doses, frequent labs. Okay, postpartum thyroiditis. Okay, so looking at postpartum thyroiditis, it's often confused with postpartum Graves' disease because some women just develop Graves' disease after delivering for the first time, and other women have a more transient thyroiditis that can occur after pregnancy. So how do you distinguish between the two? Postpartum thyroiditis has a triphasic pattern, okay? So people will start off, women, not men, right? Will start off with high thyroid levels 1 to 6 months postpartum, and then they'll become hypothyroid, and then they'll go back to normal thyroid function about a year out. So it kind of does this. It's got 3 phases. So it'll look different than postpartum Graves' disease because it'll always be, the TSH will always be suppressed. It won't go through this pattern, okay? You also have higher levels of antibodies. You might be able to listen to a thyroid buoy on if you auscultate over the thyroid. Eye disease might be present. Some of the same factors with just Graves' disease in the general population. Okay, you won't have the eye disease in the triphasic, the postpartum thyroiditis. So treatment, beta blockers with postpartum thyroiditis can help, especially during that first phase. Sometimes people need levothyroxine for a short amount of time, and then you can take it away when their thyroid kind of recovers. It just takes more frequent lab tests. Okay, so next thing is drug-induced thyrotoxicosis. Remember amiodarone messing up the thyroid? I had a lot of conversations with cardiologists. Is there anything else we can use? Because it's a pain for the thyroid. But some cardiologists, or for whatever the condition is, that's like what they have to use. Lithium is also, it causes a lot of issues. So Basically, beta blockers, alone or in combination with methimazole, should be used to treat them, but it's usually self-limiting, so that's good. With amiodarone, there's two different types of thyroiditis that can occur, and so, the decision there depends on the type that it is, and also with a consultation with a cardiologist to see if maybe it can just be removed and a different medication used in place of amiodarone. Okay? Type 2 amiodarone-induced thyrotoxicosis has to be treated with corticosteroids. So subacute and painless thyroiditis are low uptake forms of thyroiditis. Remember, with Graves' disease, toxic multinodular goiter, toxic adenoma, elevated uptake, okay? Homogeneous in Graves, heterogeneous in the other two. But with low uptake thyroiditis, this is a picture you'll see, okay? So very different. With subacute and painless, those are the main two that need to be differentiated between. They kind of have different histories with them. With subacute, you usually have some type of a upper respiratory infection if you inquire about the history of the patient that triggers something like this. There's also pain involved, which is much different than, well, painless, see, yeah? Self-explanatory. So there can be pain in the thyroid, radiates to the ears, jaws, or throat. They may have fever and other symptoms, plus the normal hyperthyroid symptoms, okay? It's firm and painful to palpation. Sed rate is elevated, so C-reactive protein should be ordered on these folks. And again, the thyroid uptake is low. With painless thyroiditis, it's more autoimmune in nature, so it has positive anti-TPO antibodies, which we talked about for Hashimoto's. It has a triphasic pattern that's similar to postpartum thyroiditis, so you'll kind of see the same changes over time, where oftentimes they'll become euthyroid without any intervention, just kind of self-limiting. Subacute should be treated with beta blockers and NSAIDs. If that doesn't work, corticosteroids are often used. With painless, beta blockers are a mainstay. Antithyroid drugs just don't work because they affect the synthesis of thyroid hormone, and the synthesis is already low in these patients, so there's just it doesn't make sense to use those. So, and often they don't even need corticosteroids either. It's pretty self-limiting. Questions? Yes?
So, going back to the scan that is contraindicated in pregnant patients, after they're treated for Graves' disease, do you put these patients on oral contraceptives for prevention, or how do you do that?
That's a really good question. The 6-month time frame is what you're looking at. So yeah, you definitely need to have a discussion about contraception of some sort, because otherwise you have just high risk of issues with radioactive iodine still being present in the system. So yes, I would have that conversation and highly recommend contraception. Yes. Anything else, guys? Okay, well, I appreciate your attention. So